Well, welcome BCIT students. My name is Lori Marchenko. I'm an interventional technologist, and I'm going to be describing how we radiographically place gastrostomy feeding tubes. So what is a feeding tube? Well, a feeding tube is any type of device. It could be a nasogastric tube, which we often see on patients, or it could be one of these fancy, and I have to tell you, this is actually brand spanking new. This has actually been only on the market for the last month. So you're going to see the latest and greatest and what I call a game changer. This is pretty much what we're going to be seeing for the next 20 years in terms of how do we feed a patient. So let's start with the basics. So what is a feeding tube? Well, it's a tube that will actually provide nutritional support. So when you're unable to swallow or eat or have trauma that you cannot eat, we have to feed you. Otherwise, you will have sort of a fairly poor outcome in terms of your health. So in order for us to do that, we can place a radiographically placed gastrostomy tube that will actually provide nutritional liquid support into your GI tract so that you can thrive. This catheter is made by a company that has called this an Intuit Thrive catheter. It's very easy to place, and I'm going to show you how to do that. So the first thing that we want to do once we inflate the stomach with air is actually anesthetize the skin. So we're going to actually puncture the skin and infuse about 10 cc's of local anesthetic to make sure that the skin in and around that area is frozen. So as we want to anesthetize the skin with some local anesthetic, I'll instruct the nurse to inflate the stomach with air. We need to fill the stomach with air because we have to hit a fairly large target. To hit a flaccid or a very small stomach without inflating it makes it very technically difficult to do so. Once it's fully inflated, then we'll actually infuse the local anesthetic. We want to make sure the entire tract from the skin right into the stomach, which is usually about 3 to 4 centimeters at least into the skin, that we'll anesthetize. And then we'll pull the needle out. So again, we're going to ask the nurse to inflate the stomach up with a little bit of air. And we're going to poke the needle all the way through the skin and into the gastric lumen. So it's going to go fairly deep, probably a good 7, 8, 9 centimeters. I'm going to plummet this into the stomach, which will release a little T-fastener. And I'm going to show you what that looks like in a moment. And once I do that, I'm going to basically cinch it up. So I'm going to grab with that T-fastener the rugal folds of the stomach and pull it right up against the anterior abdominal wall. I don't want any space between the outside skin and the patient's stomach. I usually do that about 3 times in sort of a triangular configuration just to kind of keep the stomach nice and secure so that when I put the final gastrostomy tube in, it's got a nice tight fit. I'm going to show you what that little gastroplexy fastener, T-fastener device looks like on the inside. So I've actually pulled it out of this little loaded needle, and it looks just like this. It's on a string. It's actually on the inside of this, so that when it's in the stomach and it releases itself and I pull it taut, it's going to grab itself against the stomach wall, and I'm going to get to pull it right up. So after I do that, I'm going to take this little cinching device and cinch it up so I get to pull the string all the way up and pull it all the way, and so I can basically cinch it as tight as I can, so I got very little space between the stomach and the outside world. Once I've got my 3 fasteners cinching up the stomach very close to the abdominal wall, I'm going to actually make a nice little incision so that it makes it easier for me to introduce my catheter into the patient's stomach. Next thing I'm going to be doing is introducing the catheter and wire so that I actually occupy that wire to the gastric lumen. And as I advance that, I make sure that it's truly in the gastric viscera. The next step, after I've confirmed that I'm in the stomach, is I want to dilate the tract. So sequentially, I'll take a dilator and push it into this patient's, right through the patient's skin, through the anterior abdominal wall, and into the stomach. Finally, after I've dilated to the proper diameter lumen, which is usually around 18 French, or about 6 millimeters in diameter, I'm going to take my catheter, final catheter, and advance it into the stomach. I'm going to take the peel away, which is actually, this is called a peel away sheath. I'm going to basically take that and then going to peel this away so that I can basically embed this whole catheter, forcing it into the stomach. While maintaining access into the stomach. There's a little 5 cc balloon on the end of the catheter that helps retain the catheter within the stomach. You inflate that up with a bit of sterile water, not air. Air will actually seep out over time, so we put water in. Now I got a retention disc that will actually help me even further cinch up the catheter against the abdominal wall and against the skin, so it's nicely firmly attached to the patient so it doesn't leave anywhere. There's another port on the top where you actually can feed the patient. You can do Ensure, Boost, anything that's actual liquid you can feed the patient with. These patients are recovered in their interventional recovery area for about an hour afterwards. They are sedated and they're giving a combination of wonderful cocktails like fentanyl and midazolam. So we have to make sure that the drugs do wear off. After about an hour, they can be discharged to the ward. And after that, they are recovering in the hospital for about 24 hours after that. If there is no signs that the patient has peritonitis, because that's one of the complications here, you can really, if you have, obviously you have a fairly large hole in the stomach and you've got gastric contents pouring out into the abdominal cavity, one of the known risks is peritonitis. So after 24 hours, if the patient hasn't quite had that as an issue, basically the patient can be discharged. These gastropexy devices will actually only stay in for a couple days. We'll actually snip them off, or the ward nurse will snip them off, and the T-fastener will actually fall in the stomach and be actually excreted in the patient's bowel movement, so there's no problem there. Most of the patients that we see that we require them for short-term nutritional support that don't suffer from dementia, we instruct them very adamantly that they are not to pull and tug on this for about 6 to 8 weeks until a nice column of scar tissue is formed around the tube. So if it does actually get pulled out, there's no worries about suffering peritonitis. The only thing is we want to make sure that the patient comes back fairly quickly to the hospital to get this tube replaced. A lot of these patients will require this tube to be in either sort of on a temporary basis, 1 or 2 months, and some patients actually will need this long-term for several years. The nice thing about these catheters is they do last for about 1 year to 3 years, depending on how much gastric erosion happens to this tube. It's actually made out of silica. To change these catheters is very simple. Procedure is done as an outpatient, and it just takes minutes to do. Hopefully you've actually learned a little bit more about what a radiologically placed gastrostomy tube is all about. It is a very simple device, doesn't come without its own complications. But we think that this is sort of a very important tube that you'll see in the interventional suite that BCIT techs and brand new technologists should know about.